Good morning, everyone. A very warm welcome to all our distinguished guests, colleagues, partners, and friends joining here at the BRAC Center in Dhaka. And a special welcome to those joining us on the live stream across the region and around the world. My name is Salima Sara Kabir, and it's my honor to serve as today's MC for the event. Today's event is hosted by the BRAC James P. Grant School of Public Health, a leading public health institution in South Asia with over 20 years of track record of research, education, and advocacy that spans across 35 countries. We're proud to be the host of this important regional conversation. We are gathered here today for a milestone occasion, the Asia regional launch of the landmark report, Health in a World of Crisis and Impunity, produced by the Johns Hopkins Center for Humanitarian Health and Lancet Commission on Health, Conflict, and Forced Displacement. We have an exceptional program ahead. Now, to begin, I would like to invite Dr. Laura Reichenbach, Dean and Director of the Center Center of Excellence for the Science of Implementation and Scale-Up, to come and share a few words.
Thank you, Salima. Good morning, everybody. Distinguished guests, is this on? Can you hear me? Okay. Distinguished guests, colleagues, and friends, good morning to you all. It is a genuine honor to welcome you here on behalf of the BRAC James P. Grant School of Public Health, BRAC University. We are a school that teaches in communities, researches with communities, and works to create impact alongside communities. Our work brings together education, research, and policy engagement with a strong emphasis on equity, interdisciplinary collaboration, and strengthening public health systems. We work closely with government, practitioners, researchers, and communities because we believe meaningful progress in public health depends on learning from those closest to the challenges. Events like today sit squarely at the heart of that commitment, bringing global evidence into national and regional conversation and ensuring a report of this significance does not simply sit on a shelf. We hope today's discussion contributes not only to reflection, but to practical action and stronger collaboration across sectors. This event also speaks to where we as a school are headed. Our newly developed 5-year strategic plan sets out a clear ambition to be a school that does not simply produce high-quality research, but ensures research translates into policy and practice. One of our 4 strategic pillars is precisely this: enhancing research impact through stronger evidence synthesis, sharper policy communication, and deeper partnerships with government, regional, and global institutions. A regional launch of this kind, hosted here in Dhaka, is that pillar in action. Global evidence shaping real decisions in national and regional contexts. It also reflects our broader commitment to global partnership, working alongside institutions like Johns Hopkins, the Lancet, and our colleagues across the Commission to ensure the region's voice and the voices of those we work alongside are heard where it matters. Today, I also have the particular pleasure of recognizing the remarkable contributions of colleagues from within our own community who have been part of this very important Commission's work. Professor Sabina Faiz Rashid, the Mushtaq Chowdhury Chair in Health and Poverty, our former dean and a longstanding member of this community, served as a commissioner on the CHH-Lancet Commission. Her commitment to rigorous scholarship and to centering the voices of those most marginalized is exactly what a commission of this nature calls for. Sabina, we are very glad your expertise is reflected in this work, and we are proud to have you represent the values of the school on such a global stage. I know you didn't want to hear that. I also want to warmly recognize Farzana Misha, Associate Professor, and Ishrat Jahan, Research Fellow from BRAC James P. Grant School of Public Health, who contributed as co-authors to this report. Their work exemplifies what rigorous, purposeful knowledge looks like, research conducted not for its own sake, but in service of the people most affected by conflict and forced displacement. Having researchers of their caliber contributing to a report of this global significance and doing so from Bangladesh is something this school is deeply proud of. Thank you. This work also reflects the strength of our school's humanitarian hub, which sits at the intersection of health and humanitarian crisis response, working in collaboration with our research centers to understand the gaps in public health service delivery for forcibly displaced Myanmar nationals and host populations, and to identify what is needed to improve their health and well-being. The hub's work extends beyond the FDMN response as well, reaching other marginalized communities, particularly in hard-to-reach areas. It is this kind of grounded, sustained engagement that allows our researchers to contribute so meaningfully to global commissions of this nature. Their scholarship is built on years of work with crisis-affected communities, not removed from them. As a social scientist who has spent more than 2 decades working across South and Southeast Asia and Sub-Saharan Africa on implementation science and health system strengthening, I am acutely aware of the gap that so often exists between evidence and action. We generate knowledge, we publish findings, and yet the systems meant to translate that knowledge into better lives frequently fall short. Not for lack of information, but for lack of political will, structural coherence, and equitable distribution of power and resources. That is precisely what the CHH-Lancet Commission has had the intellectual courage to name. This is not a report that politely suggests improvement at the margins. It calls for structural transformation, a deliberate redistribution of power, resources, and incentives in the humanitarian system. As someone who has led research projects in some of the world's most challenging contexts, and as all of us have worked to generate actionable evidence for those with the least access to care, I find this framing not radical, but long overdue. And for those of us working in Bangladesh, situated in the midst of one of the world's most protracted humanitarian crises, with one of the largest forcibly displaced populations on Earth, and increasingly on the front line of climate-driven displacement, this is not a theoretical conversation. It is an urgent, lived necessity. Before I close, I want to extend my sincere thanks to our chief guest, Mohammed Mizanur Rahman, Additional Secretary at the Refugee Relief and Repatriation Commissioner's Office, who will be joining us shortly this morning, and for his continued engagement with the realities of displacement on the ground in Bangladesh. His presence here reflects the seriousness with which the government of Bangladesh approaches this conversation, and we are deeply grateful for it. I also want to thank Professor Esperanza Martinez, co-chair of the CHH-Lancet Commission, for traveling to be with us and for presenting on behalf of the Commission. And I want to thank all of our panelists for agreeing to join us today and for the perspectives that they will bring to this important conversation. And finally, I want to thank everyone in this room, policymakers, practitioners, researchers, and advocates for being here and engaging with this work. The conversation that happens today and in the days that follows is as important as the research itself. We hope this is the beginning of a deeper and more sustained dialogue, because ultimately, the value of this report will not be measured just by its publication or even by the conversation it generates today, but by what we do with it. The challenge before us is not one of knowledge. It is one of action and of how we translate evidence into decisions and decisions into meaningful change for the communities we serve. We very much hope that today marks not just a discussion, but the beginning of more deliberate, sustained action. Thank you very much.
Thank you so much, Laura, for that insightful take on reflection on the importance of this report. As we wait for our chief guest to join us, we can now move to the centerpiece of our morning, the formal presentation on the Commissioner's report. We'll begin with a brief contextual framing from one of BRAC's most distinguished faculty. Could I please join me in welcoming Professor Sabina Faiz Rashid, the holder of the Mustaq Chaudhry Chair in Health and Poverty, Director of the Center of Excellence in Gender, SRHR, and also Commissioner for this report.
Good morning. I'm not sure I'm going to be providing a contextual framing because we have Professor Esperanza here, but thank you, Laura, for, I'll pay you later for those really fantastic words. I might have to pay you a bit more, but thank you. It's really, really a pleasure to have so many people join us because it's raining, I heard. There's traffic and there's probably multiple seminars going on today, but this is a very important report that it was a privilege for me and my colleagues to be part of. I learned a lot, and I also feel like the interdisciplinary nature of the individual scholars, directly affected communities, scholarship from many different disciplines coming together to understand this problem, including practitioners. I'm not going to go into the actual report because we have someone doing that, but I just had a few thoughts when I was on this 2-year journey being involved. One, I learned a lot, just quite how hard humanitarian work is, and how much it requires dedication and a commitment and not giving up. Not only actually for the directly affected communities to build the trust, to have the trust taken away, to have despair, then have hope, and then to reach out to various actors who are always there or trying to be there. And now we have a huge global sort of funding cuts, backlash, and a lot of misinformation around migrants, around refugees. I think one of the dilemmas was the label of refugee gives you access to certain benefits. At the same time, you're stigmatized forever in a label, in a box, but you're a human being. That's why it's the humanitarian, human beings. And I think somewhere along the way, we all hope to live in a world where every human being is not forced to flee, is not persecuted, or even in their own homes, whether they're migrants or refugees. As Laura mentioned, we have one of the largest settlements in the Rohingya camps, can live like anyone else and everyone else without that label always hanging over their heads, because many don't have viable options or choices. So that's something I've been to the Rohingya camps, but I had to kind of relearn, spending time in this journey, what it really means to work in the humanitarian sector, which I don't. I do research. Second point, I was going to say, it gave me great pleasure to realize BRAC is one of the largest service delivery organizations in the Rohingya camps. So I'm glad Dr. Akram Bhai is here with us today, because it gives you joy. You can live and work in a country where, whatever our politics may be, we did take in one of the largest Rohingya refugees into Bangladesh, and we're a developing country. Secondly, BRAC and many other UN organizations and other organizations around the table today are working tirelessly despite the resource constraints. Finally, I think one thing I realized in the whole discussion around colonization and localization, my own personal take, it's complex. And I think power politics operates in localization as much as it does in colonization. So there always has to be a balance and a bridge when we do talk about these transitions. And at the same time, I think we have to remember there needs to be a global accountability, because a lot of the politics is beyond the national borders that creates a lot of this crisis. Finally, I just want to say that given the changing world we live in now, disorder, chaos, crisis, there's also a lot of hope. There are people coming together. There are people who are wanting to put aside maybe the competing priorities to try and find ways of uniting to focus on what do we need to do next. I hope that happens, because I think, as Laura said, what do we do next is very important. It's the actions we take. Finally, I'd like to end with Where we are born, how we live, where we work is not decided by us. It's basically fate. And where you end up is actually affected by the politics, social, economic, cultural, and even the global sort of chaos. So I think empathy and recognition and respect for directly affected communities is key to really taking any kind of actions forward. And also recognizing that communities that are at the heart of whatever we do. And I think the School of Public Health does that well in our teaching and in our research, but to be part of such a big report that's so important and has such good key findings, critical but reflective findings, was really, really a huge learning for me. I'd like to introduce next Professor Esperanza, who's a medical doctor, who's worked in the humanitarian sector, who's now a professor of practice at ANU. ANU is where I studied. So it was nice to meet finally someone who's from ANU, who's come from Australia. I usually meet many scholars from everywhere else. So welcome, Esperanza. I know you flew in yesterday and she's still wide awake. So let's take advantage of while she's awake to hear from her. Thank you very much.
Thank you very much. And if I could please have the set of the slides. So while we get the slides up, I would like really to say thank you for hosting me. It is a privilege to be here in Dhaka with you all and speaking to the colleagues across Asia who are attending this conversation online. The report was launched in Geneva in May during the World Health Assembly, and we have done regional events in North America, Africa, and the Middle East, creating spaces to reflect how the findings and the recommendations resonate with the regional realities. And that's what we will hope to have here as well, a conversation with distinguished panelists a little bit later on. The title of the report, Health in a World of Crisis and Impunity, is deliberate. It addresses two things at once, the crisis itself and the failure to enforce the protections of health we already have. We will briefly look at some of the key challenges facing humanitarian health and the humanitarian sector more broadly before delving into the Commission's recommendations. In 2026, 239 million people need humanitarian assistance. Of these, only 87 million people, meaning 36%, have been prioritized. This is what we in the Commission call rationing by design. The 2025 UN appeal was cut mid-year from $44 billion down to $29 billion. Even at that lower number, only 55% was funded by the end of the year. Conflict-related deaths nearly doubled worldwide between 2021 and 2024. And if we look at the bottom, at financial estimates, $23 billion would suffice to cover most life-threatening humanitarian needs globally. And that is less than 1% of global military spending today. So the issue here is not an issue of money. What is missing is political will. This graph shows displacement figures over nearly 50 years. With internally displaced persons, you see this in the graph in green, refugees in blue, and the red line represents stateless persons. In 1980, at the very beginning of the graph on your left, forced displacement was a small phenomenon. Today, on the right, more than 123 million people are forcibly displaced from their homes, the highest number ever recorded. And if you look at the lines after 2011, Syria, Yemen, South Sudan, Tigray, Ukraine, Sudan, Gaza, each increase in numbers is a systematic and political failure that becomes someone's permanent reality. And the majority of those displaced are internally displaced, with displacement lasting decades. And besides the human toll, this reality challenges a humanitarian system that has been built for acute emergencies, not for long-lasting protracted crises. This figure shows attacks on health workers at the top, in the middle, hospitals and clinics, as well as supply chains and patient transport. And all have been raising up and up for the last few years. And we know that the reality is further worse than what this graph shows, and the trend for 2025 and 2026 doesn't seem to be changing. In Sudan and Gaza, hospitals have been systematically targeted. And we see the same pattern in Ukraine, here across the border in Myanmar and elsewhere. Attacking hospitals is not a tactic of war. It is against the law. However, condemnation without consequences is the norm today, and it is a challenge that we must address. This slide illustrates how funding is distributed today and who controls the humanitarian response. Under the Grand Bargain, 25% of humanitarian funding was to go to local actors by 2020. Nearly after a decade later, we are still far from that target. In 2024, only 4.3% of direct funding goes directly to local and national actors, with the remaining close to 96% going first to international actors. This is not a technical failure. It is a failure on how power, trust, and resources are shared. And this slide shows an equity picture over the last 15 years. Between 2009 and 2024, the 10 largest displacement crises have produced between 55 and 75% of the displaced populations in the world, and between 54 and 84% of all refugees. This graph shows only internally displaced persons. Yet, those same 10 crises receive only between 29 and 50% of the funding over this period. The gap has been relatively steady across this period. However, in some years, it has reached more than 40 percentage points. More broadly, when 239 million people are in need of help, and only 87 million people are prioritized, this is not an inevitability. It is a choice. The purpose of this commission was to rethink the strategies, the governance, and the delivery of humanitarian health, and to amplify the voices of those the system is meant to serve. Our work took more than 2 years, and it involved 21 commissioners and 21 next-generation scholars from all over the world. An incredibly diverse group, many of whom have experienced conflict and displacement themselves. We had an advisory committee of 29 experts, including donors, UN agencies, other multilateral organizations, and NGOs. And the commission interviewed more than 500 people affected by conflict and displacement, and humanitarian workers supporting them across 12 countries. This commission is not another call to do better, as Laura said. It is a call to do differently and to do it now. Critically, behind every statistic on those slides as presented, there is a person, there is a family, there is a community. And as mentioned before, this commission worked hard to ensure that their voices and experiences shape both the diagnosis and the recommendations. These images come from a photo voice study with displaced Syrian youth in Turkey. At the top, after 12 years of displacement, a young person is still living in the shadow of an earthquake, where walls are still scarred by time and disaster. The middle image portrays the social isolation and stigma that the young displaced student feels at her school. And at the bottom, a displaced girl shows a pot of food brought by the Turkish neighbor when her mother was sick to illustrate solidarity. Solidarity captured in a single object. To organize the analysis of the commission, we built a conceptual framework, and I'm going to walk you through 3 stages very quickly. First, if you look at the circle, we place people at the center, not the organizations or agencies responding. So we have individuals, households, and communities, along with the service providers that cater to the health needs. Then in the outer layers, we have recognized and de facto authorities, the ecological environment, and the humanitarian and development sector in which these communities live. On the left, we outline the drivers of crisis, conflict and insecurity, forced displacement, public health emergencies, climate-induced events, and other drivers of violence and conflict. And we identified 3 crisis typologies in the center of the slide. Neo-acute crisis, those that happen suddenly, acute and protracted, like natural disasters or outbreaks in areas that are experiencing long-standing crisis, and protracted crisis. And this is important because each type of crisis requires a different response. Here at the top, we analyze 5 strategic drivers: international law, humanitarian principles, governance, financing, and health systems. And they form the basis of the report's analysis and are reflected in the final recommendations. And finally, at the bottom, you find 6 themes that run across everything we propose: social determinants of health, populations in conditions of vulnerability, community engagement and accountability to affected populations, data and evidence, technology, including artificial intelligence, and localization. These themes are not chapters in the report, but they are threaded in every recommendation that follows. Now, we will move to the 4 overarching recommendations that we make in this report. Our first recommendation is to invert power. Affected communities and local actors are closest to the needs, and they are often the first ones to respond. Yet, they remain at the edges of decision about their own crisis. A health official in the Democratic Republic of Congo told us, decisions are often made in the capital or internationally, far from local realities, which leads to delays. So the recommendation is to shift governance, funding, and decision-making to affected communities and locally legitimate actors. You see that we don't use the term authorities only, as in some cases, non-state actors are responsible for delivering services and are considered legitimate by their communities. This recommendation also includes transforming existing humanitarian structures. And here in this slide, we have some examples of key actions. And I really urge you to read the whole report for a comprehensive set of actions. First, apply a crisis typology and decision matrix, because different crises need different responses. An acute emergency cannot be managed as the same as a 20-year-old conflict. And a protracted crisis should not be treated as a permanent emergency with funding disbursed on an annual basis. Second, make subsidiarity by default. Decisions should be made as close as possible to the people affected by those who are legitimate, capable, and trusted locally. The question is not which international agency leads, but who closest to the crisis is best placed to lead. International leadership should be the exception, time-limited, and linked to a clear handover benchmark. Safeguards must ensure that this power shifts to communities, not simply to global elites or to safe or gatekeepers. And the third recommendation on the right is to simplify the architecture. Today's humanitarian system is too fragmented, too competitive, and too slow. Too many agencies compete for the same mandates, resources, and visibility. We recommend creating a leaner, integrated, and accountable operational UN entity. And we also recommend replacing the cluster system and the refugee coordination model with a fit-for-purpose incident management system, particularly for acute settings. Now, to move forward with subsidiarity in practical terms, we have developed a decision matrix that asks 4 sequential questions. The first one is, what do communities define as their priorities? What are their needs, and who do they trust? The second is, who has the authority, the ability to protect people? The third, on the A part, who is already delivering care? Local NGOs, faith-based organizations, private providers, informal systems, or national institutions? And where are the gaps? And only then we ask, is there a need for international actors to fill clearly demonstrated gaps with clear and time-limited mandates? And finally, the main question in relation to the system, can the health system hold, adapt, and recover over time? Our second recommendation is end impunity. The number of attacks on healthcare have reached record numbers. Enforcement of international law is selective at best. Accountability is absent, and civilians and health workers are paying the price. A health official in Burkina Faso described the impossible position medical workers face. If I treat a member of an armed group responsible for killing my brothers, it tests my patriotism. If the government finds out, I could face repercussions. Yet, if I report it, I risk being seen as an enemy by the armed groups, which could endanger my life. The laws already exist. International humanitarian law, international refugee law, and international human rights law. They are designed to protect civilians, patients, and healthcare workers. In today's geopolitical climate, we conclude that this is not the moment to revisit those laws, because the core problem is non-compliance and no consequences. Security Council Resolution 2286, passed in 2016, 10 years ago, was meant to protect healthcare in conflict. Nearly a decade later, follow-up has been limited, accountability remains weak, and impunity persists. And here are some examples of key actions under this recommendation. First, create a global alliance for the protection of health in conflict, and a standing platform of states, UN entities, and NGOs that act in a systematic way when health protections are violated. The response must be diplomatic, legal, political, and operational. An attack on a hospital should trigger consequences, not another statement of concern. The second point, on humanitarian principles, we reaffirm that humanity and impartiality are the non-negotiable foundations of humanitarian action, as they provide relief based on need without adverse distinction. Neutrality and independence remain essential, but they are context-dependent. Importantly, and we really highlight this, being neutral is not a precondition for protection under international humanitarian law. And we advance 3 other core contemporary principles: do no harm, solidarity, and accountability. And on the third point, use health outcomes as accountability indicators. Excess mortality, service disruption, and exclusion should not be accepted as the inevitable cost of war and should trigger formal accountability processes. Our third recommendation is fix the money. Humanitarian financing is still too short-term and too earmarked. It is also donor-driven and increasingly used as a foreign policy instrument. A local NGO field coordinator in Turkey told us, this is a field largely shaped by donors. We do whatever the donor asks us to do. If a donor says psychological support will not be provided or mental health and reproductive health will not be provided, NGOs generally don't reject this. That is the problem. Funding decisions too often determine what counts as a need instead of the needs of people determining where the funding goes. So we are the other way around. And here are some of the examples of key actions that could be taken under this recommendation. First, create an independent multi-layered pooled humanitarian fund with allocations based on assessed need and equity, not on institutional mandates, donor preference, or visibility. Second, expand cash-based assistance. The evidence is strong. Cash gives people agency, strengthens local economies, and is often more efficient with the right safeguards. Third, integrate humanitarian financing with national health insurance and social protection systems. Parallel structures are costly, duplicative, and too often exclude displaced people from systems they are entitled to use. And fourth, use innovative financing tools, including responsible private sector engagement that are adapted for conflict, affected, and displaced populations. And our fourth recommendation is uphold health for all. Universal health coverage is one of the great global health commitments of this century. But people affected by crisis and displacement are often served through expensive and duplicative parallel systems. And we often do not use the mechanisms in place to effectively integrate local expertise. A refugee in a camp in Jordan told us, there are many Syrian refugees in the camp who are in the medical field, nurses, doctors, pharmacists, dentists, and lab technicians. If they were given professional practice licenses, they could work within the community and help improve services. That is a policy failure, and it can be fixed. And here are some of the recommendations of key actions in this recommendation. First, make the right to health the test for every decision. Service delivery, coordination, and transition should be all judged by one question. Does this expand equitable access to those most in need? Second, ensure continuity of care and connect humanitarian health services to national systems from the start. Third, protecting healthcare and civilian health as a non-negotiable right and as a shared obligation across states, non-state actors, and the humanitarian system. And fourth, build health systems for climate shocks and responsible technology. Conflict and climate shocks are no longer separate emergencies. And technology, particularly AI, has huge potential, but only if it is used with safeguards for equity, data protection, and human oversight. Our diagnosis is clear. Incremental reform is not just inadequate, it is dangerous. It gives cover to a system organized around donor control, not around people's needs. The current difficulties and disparate circumstances that we find ourselves in now also create a rare opening. The Humanitarian Reset, the UN-80 initiative, and the Accra Reset are all happening at once. For the first time in decades, the system is unstable enough to truly be remade. The question is whether we use this moment to protect the status quo or to build something better. A health professional in Syria told us, the real issue is that some donors not only expect you to remain neutral, but also threaten to suspend your funding if you show any bias towards the victims. That is the system we have. The 530 lived experience voices that shape this report are not waiting for another reform discussion. They are waiting for protection, accountability, and a system that treats them as equal actors. The Commission is calling for everyone to act. We have developed 8 policy briefs for different constituencies, affected populations, national and subnational authorities, local and national NGOs, regional bodies, international NGOs, UN and multilateral organizations, donors, and academic and research institutions. The full report is now available in the Lancet page, and you can access that through this QR code. I will close with the voice of a senior NGO staff member in Turkey, who said, after addressing immediate needs, the momentum waned. Promises were made, but once the initial phase ended, support diminished, leaving people feeling abandoned. Our job, every one of us in this room and online, is to make sure we seize this once-in-a-generation moment and that we do it together. Thank you very much.
Thank you profoundly, Professor Martinez. The depth and the urgency of the Commission's findings are clear, and I know we're looking forward to continuing this conversation. We have time for maybe 2 or 3 questions before we move on to the next segment. So if we have any questions around the room, Professor Martinez is able to answer. Or comments, we're also welcoming comments.
Thank you very much for presenting this important report. It's so important for not only for the humanitarian context, but also for like health systems overall, because all the factors that you mentioned in the report, those are actually across all the overall health systems that we are facing. But I really appreciate of the report recognizing non-state actors, because this group of actors is someone that we often ignore or don't include in any decisions, in any discussions. So I really, really appreciate that, because if we talk about localized solutions, they are the drivers of localized solutions. They are the main actors there. And also I really appreciate for like recommending local governance models, which is also very important if we want to really, really solve problems that people are facing locally. I just wanted to reflect on that this actors, they have the power, they have that local trust, and they can be the change makers, and they can also be like inhibit the changes. So I think it's very important to include them, not only just delivering services or implementation, but from the very, very beginning of when we're making decisions, when we're designing programs. Thank you. I'm Dr. Basira Akhtar. I'm working with BRAC James Spriggan School of Public Health. Thank you.
Hello, 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 hello. Mic testing. Hello, hello.
সিস্টেম ঠিক আছে থাকবো থাকবো না তো জানতো উপর দিয়ে যাবো না আরো চলান এটা খুলে ফেলাম না সমস্যা কি খুলে ফেলাম বাস এবার একটু এবার একটু ওই যে এক কাজ করে একটা মাইক্রোফোনে কথা বলো
Hello. Mic testing. Hello. All clear.
ঠিক আছে
coming back timely. May I request everyone to please take their seats? Before we begin our panel discussion, we are honored to be joined here today by our distinguished representative of the government of the People's Republic of Bangladesh. We have our chief guest here with us today, Mohammad Mizanur Rahman, Additional Secretary of the Refugee Relief and Repatriation Commissioner's Office, to share his remarks on behalf of the government. Mohammad Mizanur Rahman serves as the Additional Secretary and is responsible for overseeing policy and operations related to the Rohingya refugee response, one of the largest and most complex displacement situations in the world. Before I invite Additional Secretary Rahman to join us, could I have Laura on stage to welcome and thank our chief guest? Mr. Rahman, please join us. So we would love to hear a few words from you. Sir. Ladies and gentlemen, Additional Secretary Mizanur Rahman.
Assalamu alaikum and very good morning to all of you. I missed the first session almost, the presentation. Just at the end of the session, I was enjoying actually. Thank you very much. Thanks BRAC University for inviting me. And I was thinking, what should I share with this very, very important gathering here? First of all, let me introduce myself. I'm working here as a government official, undoubtedly, for more than 3.5 years in this capacity, Refugee Relief and Repatriation Commissioner. And I'm Additional Secretary to the government. But I had been here in 2017 also, when the people started coming from Myanmar to our territory. And I was given the responsibility to help the international community, particularly the IT engineers of UNHCR and IOM, to demarcate the reserve forest area, to just identify the location for the shelters, for the facilities, for the hospitals, for distribution center. So I'm the only government focal there to be accompanied with the international community. And I found, very interestingly, it was very, very encouraging for me. I found an Australian gentleman who was in the forest providing health services to the people who came just across the border. And he used to work for at that time for MSF. I was acquainted with MSF the first time in the jungle. Then I became fan of the health workers, particularly MSF. MSF, to the government, MSF is an organization always not cooperative to government as the blame they are giving. But for me, I was always advocating for MSF because I saw I was the witness of this, services inside the jungle. At that time, there is no sanitation, nothing, just open sky, We used to use the, long jungle boot, and it was a horrible. And I lost my 3.5 kg weight at that time in 3-4 months. It was this sort of monsoon, late monsoon rather, it was September in fact, late monsoon, and no sanitation. And for the first time, I saw the BRAC symbol in those areas. They started installing the latrines. And it was the first time they used to install the latrines with very temporary nature, and it was overflowed by within very short time, within 1 week, 2 weeks, 3 weeks. And the newspaper was bullshitting BRAC at that time that the BRAC is wasting resources in the jungle, because that was the fastest, but they did not have that experience. How many people will cross the border? Nobody could understand at that time. Nobody could forecast how many people are coming. We are not ready, actually. We are not ready to receive. And so far, till today, I studied the history of human exodus. So far, this is the most speedy human exodus. Within very short time, within 3-4 months, 750,000 people crossed border, according to UNICEF data. Now it is 1.2 million people are living in this one of the largest refugee settlement in the world. So if we come to this, the health in the crisis situation or an impunity that is going on in Rohingya crisis response in terms of health. These people came, unfortunately, they came with diphtheria. That disease was unknown in our country for last 2 decades even. We eradicated diphtheria in our country, but they came with diphtheria outbreak. And diesel outbreak, cholera outbreak at a time. But Alhamdulillah, it did not happen as it happened in 1978. So far at that time, 10,000 people were missing because of the cholera and other things. During our liberation war, you might have known that 10 million people crossed border to India, and some people even crossed border to Myanmar. And at that time, tens of thousands people died of cholera, our Bangladeshi people in the refugee shelters across the India. But this time, there was not that sort of casualty happen in Cox's Bazar. Situation was almost out of control, but government, the people, individuals from that community, particularly the host community, they shared their estate, they shared their paddy field, they shared their house, they shared their food, and people from all the parts of Bangladesh, they jumped. And government, not only sent me, the around 100 civil servants were posted at that time there. And military were deployed in aid of civil power. And lot of facilities were installed by this time. And some even government they came. Malaysian field hospital, Turkey field hospital, even Iranian hospital, Japan Red Cross, German Red Cross, the Norwegian Red Cross, they all set up the hospitals. And at the moment, we found that more than 150 health facilities were installed. And many NGOs like BRAC, many NGOs, are working in health sector particularly, international NGOs, they came up. And interesting thing that there was a lack of coordination initially. We tried to set up a coordination mechanism. I understand the report addresses the issues like international law, humanitarian principles, and governance, the financing, these all issues this report addressed. And I also, I also agree with this report. Yes, there is a lot of room to work in governance, in coordination mechanism, of course, Bangladesh is not the signatory of international convention, but we cannot differentiate when one patient comes to a doctor. We cannot ask him whether you are a refugee or Bangladeshi. That's the principle, And when the people, I was just accompanying one of my border guard high official while I'm coming to Dhaka, just sitting beside me, who are sharing. He told me that, look, when the people came across the border with, pain of pregnancy, delivery, with bullet injury, we cannot prevent them coming inside the country. And this is happening. Still, more than 50 people are coming every week. And this put a lot of pressure on us in the locality where the Rohingya people are living. This is a very small locality. It's a, steep peninsula and difficult terrain with hilly lands. On one side is, Naf River, the border, another side is the Bay of Bengal. And people of that area, traditionally, unfortunately, they were suffering from different health problems. For example, stunting or, other, health problems they're suffering from. And this is the pocket of poverty, in fact, the Teknaf Upazila particular, Teknaf sub-district. And they are not richer, that much richer than the Rohingya people even. They are the low-incoming people in our country. This is not industrially developed area. Their only livelihood is soil cultivation or fishing, So in this area, the people came. And now still we have 120 health facilities in the camp. And these are divided into 3 categories in terms of service provision. One is the health post that works for official time is 9 to 5 o'clock. Another one is the primary health care center that is working for 24/7. And another one is the field hospital. We call it field hospital, a kind of, referral, hospital they are providing is 5-6. And MSF is still the largest health provider there, actor there. But what is government doing? In 2 sub-districts, we have the Upazila health facilities and also we have some union health facilities. We have been supporting on behalf of UNHCR, IOM from World Bank, ADB funding. We are trying to support these Upazila hospitals to make it secondary, referral hospital. But they have their own limitation. You understand, the Bangladesh is always, trying to work for their people in education and health in those 2 areas. Still, we have a lot of things to do. And in last budget session in the parliament, almost every opposition MPs, they criticize government to make more budget for health and education. And this is the demand from the people. And we cannot justify actually our inaction, government inaction in health and education. We are lagging far behind. And we are talking about the refugee people here. And the reason of this crisis, the problem of this crisis, the root of the crisis is not in our land. It is in the other part of the border. We are simply innocent victim. So I can I can tell you for climate, the climate change, Bangladesh is also another, initial victim. And a lot of people are now migrating from here and there. And if you walk through the street of Dhaka city or Chittagong city, you will find a lot of people are staying on footpath, on roadside, and slums are growing. So in both area, the report addresses. I thank that I did not have that depth, reading of the report, understanding the report, but what I understand, this is a very important document, not only for me as a refugee commissioner in Coxbazar, but for the government of Bangladesh also, for health ministry, for the health professionals who are working here in Bangladesh also. So I thank you very much for this wonderful report, and hope in the days to come it will be giving us some lights, insights to work for the people. And I can tell you, for Rohingya people, this is the 9th year almost. We are going to finish in July. And there is, as I told you, that every week we are receiving more than 50 individuals. And there is no that much hope that these people will be repatriated very soon. Though government has the, intention and target to repatriate Rohingya people back their home with dignity, with some sustainable solution. But the conducive environment on the other part is almost a far cry. Still, every day we are receiving the war-like situation is going on. The news we are receiving, the people are being attacked by air strike and some other, casualties is going on. So it is very, very uncertain situation regarding the repatriation. Till repatriation happens, we must provide at least dignified, life to this camp dwellers. Camp is not a place to live in. And when you visit the camps, you see the 10 by 15 square feet area was allocated for a family of 5 or 6 members. And last year or before last year, we saw that the 60% of the people are suffering from skin diseases, scabies. And according to latest survey, we found that, 15 to 20% of the prevalence of hepatitis C, when our national average is, I think, around 1%. And this is very, very dangerous symptom for public health. So we have to address all those needs. And very recently we, complete the several rounds of vaccination program. It's around 92% for measles this time. And it's thanks to all the actors who have been working here. One good thing that I personally, I'm not a physician, I'm not a medical background personality, from a journalist from background. I always ask our government department, health department, even when they visit Coxbazar, I encourage them to visit Cox camp, because we have some good practices in the camp that is not even in our in Bangladesh. One of the good practices is the referral system in place. One of the good practices is the health card we issued. One of the good practices is that the NGO-run hospitals are cleanly, and cleaner than the government-run hospital sometime, One of the good practices that the doctors are very much, dutiful in the hospitals. That is sometimes a criticism in our public hospitals. In a rural area, people are blaming that the doctors are not going to rural area, but that is not happening in Rohingya camp. It's a far rural even. It's a very difficult terrain. Still, the doctors are going there. Some are staying in Uki and Taknaf. They are providing services. And one of the government doctor told me he used to be in an NGO-run hospital in Coxbazar. He told me that I enjoyed my job there. Now I am not enjoying. When I was conducting a training session in a doctor's classroom, he confessed this. So that is the good practices we had. And everything is not bad in Rohingya camp. Many good practices are there, and even government can learn from them. I always encourage our government, stakeholders to go inside and see. And you see the people there, even the Rohingya people. If you visited these people in 2017 or early 2018, and if you visit now, you will clearly find the differences. The people are now laughing. Their faces are flashing. That was not the case in 2017. They are so gloomy, melancholic, They were so hungry, looking so hungry. This is not happening now. And the cholera, diphtheria, these are now under control. There is no outbreak. Even measles, during the measles, you see the many casualties in our Bangladesh, many districts. But in Rohingya, only 5 mortality. Only 5. Thanks God, thanks to the actors. With this, I want to conclude. It's a lot of stories to share. But thank you very much for inviting again. It will be a wonderful lesson for me also. I want to enjoy your other presentation also. I missed you, but I will get to your report, inshallah. Assalamu alaikum.
Thank you so much, Additional Secretary. It was really inspiring hearing your real life, grounded experiences and anecdotes from the field and camp that echo the findings of the report. And we really appreciate your comment, recognizing the importance of this report and the role it may play in informing other government officials about the dire situation that's existing in the camps and the work that, while great work is being done, the work that's still left to be done. So we really appreciate, one, you being here, but also sharing such insightful comments and experiences with us that help really ground this report in something meaningful. With that, I would like for us to now move on to our panel discussion on health displacement and systems transformation amid climate and humanitarian crisis. We'll be posing the question, how can countries facing displacement, climate shocks, and protracted crisis move beyond emergency response towards sustainable, locally led systems and financing models? And please join me in welcoming Dr. Farzana Nisha, Associate Professor and Lead of the Climate Change, Environment, and Health Club at the Scholar of the Lancet Commission, our panel chair and moderator. Okay. May I request our esteemed panelists to join us on stage, and Misha Appu will introduce each of you. Dr. Akramul Islam, Juliet, I hope I got that not too terribly wrong. Dr. Syed Ahmed, Shahir Sadat. Tags around the secretary.
Hi, everyone. Good afternoon. I might say good morning, 15 minutes till it becomes afternoon. So we have just heard from our honorable chief guest. It was a wonderful speech to know about his experience and what the government also went through. And before that, we also heard from Professor Sabina and also Professor Esperanza, who lay out the report we are talking about today. And as we have seen, that in this world, right now, there are 239 million people who need humanitarian assistance. And of them, 152 million will not receive it. So this report is not being delivered to Bangladesh from somewhere else. The camps it studies are a short flight from this room. And the health workers it writes about are some of the people sitting here with us today. Right now, we are hosting 1.3 million Rohingya refugees, a crisis now in its 9th year. And we are also on the front line of climate-driven displacement. The people sitting at this panel today represent the full shape of the response. We have agencies mandated by the government, by the world, to ensure no displaced person is left without protection. We also have from organizations that has built health system at a scale and depth, working inside the camps to deliver the care that others have found too difficult or too politically inconvenient. And also institutes asking the question that hold all of this together. When the system fails, who answers for it? So now I'd like to introduce our esteemed panelists. On the other side, we have Dr. Akram Islam. He's the Senior Director of BRAC's Health Program and Humanitarian Crisis Management Program with 3 decades of experience. He has built health system in the community, in the camps, and at national scale, from tuberculosis control to the Rohingya emergency response in Cox's Bazar. Next, we have Juliet Murokesani, Deputy Representative of UNHCR in Bangladesh, bringing 20 years of humanitarian experience across 4 continents, from Peru to South Sudan, Yemen, Ethiopia, Western Sahara, and Algeria. She has also written with great clarity and courage about her own experience of being born a refugee, a perspective that brings something to this conversation that no institutional brief can replicate. Next, we have Dr. Ruba Said Ruba. He leads IPRES Bangladesh, where he has spent years doing what many said couldn't be done, delivering comprehensive sexual and reproductive health services inside the Rohingya refugee camps at scale with quality. A medical doctor with an MPH, he previously worked with Save the Children and WHO Bangladesh. And last, we have Mr. Sharia Sadat, Executive Director of the Center for Peace and Justice at BRAC University, a Supreme Court advocate with a background in economics and over 20 years experience in human rights, legal empowerment, and mediation. So as we have seen during our presentation, there were 4 recommendations by the Commission. So we will be discussing primarily 4 questions, each related to the recommendations. So the first question is regarding the first recommendation, which is to invert the power to shift governance, funding, and decision-making to local and community actors. So my first question is to Akram Bhai. So the Commission recommends give local actors real authority, not subcontracts or coordination roles, but genuine decision-making power and direct funding. So BRAC is often cited globally as a proof that this can be done. So to your mind, is localization as currently practiced a genuine power shift, or it's largely a rebrand of the same international architecture where local organizations as implementing partners rather than leaders.
Yeah, thank you, Isha. I think it's a mix. The questions you raise it is that at least for the Rohingya response in Cox's Bazar is a mixed situation right now. We really can't say that all power shifts to these local actors, but also that we can say that still the international peoples, international agencies being dominating the decision making. So it's a mix. So let me give one or two examples how we shaped this whole process for the last 8 to 9 years when I focus on health. On the BRAC example, because we do have resource mobilization from agencies, and we do also mobilize resources from the bilateral channels through the bilateral donors. And that gives us power in hand, so we can decide what really needs in. But if we only used to be as a subcontractor or maybe even as a kind of implementing partners, we didn't have that power of say on the table. So that is one of the beauty that we started when we started the responses in 1917. So we mobilized resources for the two streams so that we could raise our voices as a local actors. We can raise the voices of the Rohingyas that they faced in the camp. We know the country, we know the context of the host community, what they are being enjoying now and what the people are not enjoying. So from that is why we started the journey with a mixed funding mechanism rather than depend on the one. This gives a number of examples here. In a recent prioritization process in the Rohingya camps, when this US funding cuts happen, who should get more resources? What are the components? For example, in the health, the community health, the preventive side was not in the priority one list. So priority one list is only the primary care, medical care. But we forgot that if we do invest money in the prevention, we need to come to the facility. So we urged our colleagues and WHO colleagues, because they have been leading the sectors. We urged our UN colleagues beside me as well, one, and other NGOs. So we really can't do it. Of course, people come to the health facilities, they need care, but we also need to improve interventions. People clearly said, we had the Bangladesh experience. In 80s, this it is a preventive care. Examples of the immunization program with the national program to raise from 2% to 80% coverage. And this is the experience in Bangladesh that we have it in the country. And we can transfer these experiences to the camp as well. So there's measles coverage, as you said, there's so almost over 95%. And mortality is reduced significantly. So if we can bring those preventive interventions on the ground as a priority, you do not need to take care of many people on the primary care hospitals or the clinics. So that's the one example. So I'm just giving you how this, and I think the colleagues and the other agencies are now understanding this, the priority, what should be the priority in not inviting many people to the health facilities, rather than making this prevention more strongest at the household level so they can prevent their own diseases like diarrheal diseases. They can manage themselves. They need to be cleaning. Let me give another examples how we work also with this, the cluster system. What this you said it. We, as BRAC, we're strongly advocating for the last couple of years that mental health, and nutrition should be under one cluster. And very strongly we raised to these sectors in the Cox's Bazar, in the Dhaka, and the donor community. Unfortunately, and the government, because Triple RC was one of the person who really have a very strong advocates of many changes on the ground, and is being the witnesses. And now mental health is in the health. It doesn't need to be another cluster to be, but still nutrition we need to go more. So we need to work on that. Nutrition is still in the other cluster. That's what the challenge we have faced, when you have the cluster system. But that needs to be done together. And another example, sir, I would like to give it to you, that in the camp, the wash sector had a hygiene promoter. Health sector had your community health volunteer. Hygiene promoters only give education on the hygiene promotion at the household level. Health volunteer also do a very similar types of preventive message, which is also the hygiene promotion. So we told everyone why you are putting two people in one work in the same household, and you are just wasting the resources on the ground. Whether you invest these resources to other places. And now we have been introducing, we already introduced this hygiene, integrate with hygiene education with the health. So there is no need of two people going to the same household to the two different times. So it's already integrated. So this is the way, you know, when we ask the community, you know, the community in the Rohingya responses, in the Rohingya community, is it good for you or not? They said, in the previously they come number of people at our home, maybe 3, 4, 5 people with the 3, 4 type of messages. Basically, and we need to attend everyone. So if you can reduce that time, so that's why they can also spend some time for the other activities. So they were happy actually. So the number of things, that's why I say this already is not all that we can say this being, you know, the design somewhere else and putting there, but this already started changes on the ground. And I will come on another issues, that's the national system that I'll come on that. Is this TSS are clearly mentioned that the immunization, this is all the national programs being engaged in, you know. The resources might have a different way of channels, but what the standards that comes in, the infectious diseases like tuberculosis, HIV, malaria, this is all a national programs comes in. So there's already system in there. The referral system is already in place, even in the district hospitals. Yeah, of course, there are some challenges still we demand to do it. So the number of examples that's been changed happen on the ground, but still I believe that many agencies are still using the subcontracting. We have a limited voice to the local actors because that needs to be corrected actually. Otherwise, we cannot stop the wastage of resources on the ground. So thank you.
Yeah, and clearly the local knowledge that the BRAC and other local agencies have acquired, it's absolutely necessary if we want to effectively deliver services to these Rohingya refugees. There's no question about that. But when it comes to inverting the power, during our presentation, we have seen that only 4% of the funding went to local actors. So from where I sit, there is one issue that needs to be addressed. Like you have the knowledge, like the local actors, they have the knowledge, they know how to use it effectively. But if there's not enough funding coming to them, then it's difficult to, you know, like address all the needs the refugees are facing right now. So following up with what Akram has said, my next question is to Julia. So UNHCR is one of the institutions the report asked to reform most significantly, to plan its own phase down, to justify its presence on a defined timeline, to transfer authority to local actors. So what does that actually look like from inside UNHCR, and whether this organization is having that conversation at the moment?
Thank you very much. First, I would like first to say thank you very, very much for the report, for the presentation. It was very practical. And I like what you say last, that this is a time to change or never. When I was listening to the presentation, it's exactly what we have speaking in our presentation. It's clear. Clear is that we used to work. And not only us. That's one. And when we talk about localization, we are talking about it internally. And I'm very happy that our chief guest is working closely with other organization. So yes, we're talking about localization. Yes, we're concerned about localization, and yes, we're supporting about localization. But the question is how to make it happen. So as you say, it's now, never. Those are the recommendation you have presented. I think we need to share this report with everyone. And as my brother who has said, we are talking about localization, but in this year, we are giving up to doing it's not that we are withdrawing. We are making sure that what we are handing over, it's responsible. You are going to take over. For example, I can tell you that in UNHCR right now, we are handing over WASH. We have been working on WASH for, I think, since the 17 we are here. Maybe since the 31st with the TACNAF. But with all that's happening in the world, and we sat together, we said that, what are we doing WASH? Let's hand over to BRAC, who's doing WASH in the camp. Let's hand over to UNICEF, who's doing WASH, and with the other organization, also local organization, who can do that. So that's one of example. We noticed that this is a time that we need to grip our footprint in the operations, but not doing everything. So that's, for me, it's a part of localization. And also another thing you mentioned in your report, we talk about localization. How long have we talked about localization? Many years. And still we are talking, but then we don't put it in implementation. And also for the local organization, when they say, yes, we are ready to take this task, it's not only, in my point of view, it's not only to say we are ready to take this. We need also to push. We are ready to take this, we can save this amount of money if you are handing over that to us. So I think it's both ways. We have to release what we are doing, where we think other person can do it better, and that person also, the organization have to come also show us we are responsible, we are going to do it even better. So I think localization, we'll keep talking about it internally, but definitely it's not an easy task. It's not something that can happen today, but something need to happen now. And I think my brother also from the government mentioned that when the refugee came here, who were there to receive them? Was it the local individuals? Yeah, you met someone who is working in the bush, local organization. So it's possible. It's just how we can make it happen.
Thank you, Julian. If any of our panelists wants to add anything. Okay, so we move to our next question. So that's our next question is regarding the recommendation on where it says end impunity, enforce accountability through law, ethics, and humanitarian principles. So my question is to Dr. Rubaiyat. So the report finds that most deaths in conflict and displacement settings are not caused by violence. They are caused by the collapse of health system, disruptive vaccination, untreated chronic disease, and maternal mortality. So you work inside the reality in Cox's Bazar. What is the most fundamental thing that is broken and that doesn't get talked about enough in the global conversation?
Thank you. I think, first of all, I would like to thank to the Commission for the report, and at the same time for launching it in Asia and in Bangladesh, as well as organizing and inviting us for this discussion. I think in most of the setting which we also experience, particularly in our humanitarian crisis settings in Cox's Bazar, the most important thing is that we on the accountability issue, we focus on what our perception is, not very much focusing on and listening the people who are affected, who are living in a miserable life. And most important thing is that we start thinking this is a temporary issue. And the donors start planning for a very short-term funding and an ad hoc planning without considering the events in the life. In the life, particularly for the women, for the girls, their reproductive health is affected, but they also faced with unintended pregnancy. They suffer with sexual and gender-based violence. They also face the obstetric events, particularly as a mother during their pregnancy or childbirth. These things need to be bring into attention. And I think we need to focus on accountability, and that accountability for the women and girls need to be considered as a continuous availability of respectful, high quality care without any stigma, without any bias. And that's why we need accountability from the donor perspective, the country context, and even for the people who are engaged in the humanitarian response. So another important thing is that the local health systems need to be strengthened and capacitated to respond in humanitarian crisis, as whether it is by internal or external displacement. And at the same time, the capacity of the country, government, and as a whole, the national capacity need to be bring into attention and focus on strengthening the national capacity for a prompt response, not only waiting for the international actor to come and acknowledge and raise funds, and also availability of the resource, regardless of the political priority. We always wait for the media flashes and then respond. We need to focus on the real ground needs, and we need to listen the community who are affected, whether they are from the Rohingya refugees or they are affected by the climate and become a climate refugee. Thank you.
Thank you, Dr. Wad. So my next follow-up question is to Mr. Shahryar. So from a protection or accountability perspective, when health systems fail displaced population, who is responsible? Is there any legal or institutional framework that assigns accountability, or it's considered as a cost of crisis?
Thank you. First, to congratulate the Commission for this wonderful report. I think it brings up some real issues. And sometimes these reports are diplomatic, but I'm glad that this was not. And it brought some real issues and identified them. Now, I would say that when the system fails, before we say that who answers, I say who suffers. It's the people who suffers, and it's also the health workers who are actually take that burden of that failure. Now, I would want to take one step back. Is that let's talk about Bangladesh. That the Rohingya refugees did not come for the first time in 2017. You know, in post-independent Bangladesh, they came in 1978, they came in 1992, some trickled in 2000, 2006, and there was another shorter, smaller influx into 2012, and it continued beyond 2017. When I started working in Cox's Bazar, and when we have started setting up the refugee studies unit, I was looking for previous documents, books, histories, knowledge materials to learn and couldn't find much. So which means that we actually failed to learn from previous influxes, and we became quite reactive to. There is a problem, there is a crisis, and we reacted to it broadly. And and, and then if you look at globally, it's kind of same in other countries as well. Countries are not prepared for these kind of influxes, and so the governance, refugee governance, in many countries become ad hoc. You do take steps as things happen and becomes ad hoc. Some countries became proactive. For example, say Germany. What they did, they immediately realized after the Turkish, and Syrian influx, they immediately realized that they have a vacuum in their governance structure. So what they did, they passed laws. I think, and Bangladesh not being a signatory state to the 1951 convention, to our credit, we created our own standards in beyond, post 2017. But I think our governance structure need to be streamlined. From our center, we actually looked at legislations of more than 80 countries, and we have drafted a model law for refugees, something that's worth looking, because our point is, as Mr. Mizan has mentioned, that this is going to be a protracted crisis, since what is happening on the other side of the border. So when the refugees are here, we need to create certainties. We need to create a decision-making process where it is not based on individual personalities, and I think that is important broadly, and that would create an accountability mechanism for the future. Thank you.
Thank you, Mr. Sharia. So my next question is also to you and also to all the panelists. So this one is based on the third recommendation, where it talked about fixing the money, the funding flow. So along with the second recommendation to end impunity, we need to fix the money as well to move towards needs-based financing independent of donor political pressure. Because from our experience, like while we were working on the report, what we have seen that the decisions that are made with the big part of the funding, there is some political motivation. They decide like, okay, most of the funding should go to this humanitarian crisis, less to the other one. So because the money is coming from certain sources. So from a legal accountability standpoint, where are the realistic pressure points and what accountability mechanisms are most critically missing from the current architecture? So sorry, it's almost the same question again, like how do you fix that? How do you make agencies or government accountable that if this is not done, which in most of the cases, that's the case, like there is a crisis, there's not enough funding. Sometimes whatever the funding is, it's not spent effectively. But then again, who do they answer to? Because if there is no accountable mechanism, then there are chances that they will get away with that. And in the report, we have also seen that the attack on healthcare workers, like there are more than 3,000 attacks on healthcare workers in humanitarian crisis zone only in 2024. That's in 1 year. So when things like these are happening, how do you make those who are creating this problem accountable and make sure it doesn't get repeated again?
On the point of attack on the healthcare workers, let me highlight an issue here. You know that every year there is a global rule of law index is published. In 2025, there were 142 countries were part of that global rule of law index. We rank 125, and we have been consistently doing badly in that rule of law index. It's an indication of overall judicial system process in the country. Now, I sometimes teach refugee law to master's students, and what I did in a classroom, I asked my students that can we have a look at from 120 to 142 these 13 countries and see how many of them are refugee origin countries and how many of them are refugee hosting countries. And out of those 90% are either refugee hosting countries or refugee origin countries. That means there is a clear correlation between people becoming refugees or countries hosting refugees and the rule of law. And I think if a country's rule of law is not strong enough, that country will not be able to protect not only just the frontline health workers, but many other people. I think that's an issue that needs to be addressed with governments, individual governments, and take it to them and seek remedy accordingly. I think that's the very common sense solution I think we need to think about, and I think that's a lot of advocacy needs to be done with individual governments. That is important. And in terms of when I was listening to the conversation, the report, I was also thinking about, let's think about what happens to a victim of physical assault in camp. What are not only just the health workers, but any individual living in camps who's a victim of assault, how this person can access justice. Do we have court in Ukhia? No, the courts are in Cox's Bazar. And they need to, from the camps, they need to go through several layers of administrative process before they can actually be in court. The same thing happened to someone who has been arrested. How do we ensure that these people they get proper access to justice? And the one difficulty, one very important point that we sometimes or most of the time ignore is the language. I think a lot of things gets lost in translation. Be it for a victim, be it for someone who has been arrested. For all of them, I think when we are talking about accountabilities, we need to also take into account of these very crucial issues. And the last point I want to mention, although I missed it, when we are talking about localization, CPJ actually has done the work on localization back in 2019. And we are still talking about, to our disappointment, we are still talking about localization. The transfer of, it's not about only transfer of funding, we keep on talking about it, but also talking about transfer of expertise, creating legal framework to facilitate local organizations. BRAC has this pool fund, which is fantastic to support the local organizations in terms of governance. And for all of you to know that Rohingya youth has created an education board. They themselves have created an education board, bringing all the private tutors under their one organization, and they have conducted combined exam this year. I think these kind of initiatives needs to be looked at, needs to be recognized, and we need to start working with them, because we keep on talking about expertise. Is it this expertise that is coming from abroad, or what about the expertise from the ground? We need to acknowledge them and we need to work with them. I think that's important as well. Thank you.
Thank you, Shaya Bhai. Yes, Akram Bhai, please.
I think I also need to add in here the fixing money, these points is a very important point actually. the one key challenge, at least for the Rohingya responses, what I see is the capturing the past experiences and doing the future plan based on the experience. That's really one of the critical part that we're missing in. In many, expatriate experts, basically they stay here but short duration. They don't have a long duration stay. So what they gain and they move away, basically difficult to get this information from them. So I think here the solution could be the listening to local actors, local implementers, because the knowledge will do them actually, But if you just bring the new experts coming from the different context and giving a different, way of suggestions, that might be losing the resources that we have it already in the ground. So maybe that's one thing that we really need to fix it up. The second thing that I also add to have a standard, because colleagues are also here really on that. Standard means standard services are going to this community because they are being deciding in the both. At least for this Bangladesh one is almost same place. It's they shared each other, Other people have say that the beautiful facilities. By the way, if you go to this just crossing a 500 meter, you'll completely find a different way of approach of working. So standard may be another area to look into. What is this at least for this regional context? Standard looks for the regional context. So when you see this regional context, at least for this regional context, you might find this, this the efficiencies that you can use for other purposes. So do you really need all this intervention that we're giving in the there, or do we really need to prioritize some of the intervention that you really need to give in the ground? Because other side they're not getting it actually, So you really need to fix it up actually. So the standard needs to be fixed up based on the country where they came, origin, also the what they're deciding in, because there's host also have a similar, otherwise there will be always a tension, and then raising the host is also another strong voice. What is our the services? What is our part of the standard? Because you are having different standard there, which is across in a few meters. And the third point is the at least for this Cox's Bazar is capturing the Rohingya voice is very weak. I think let's acknowledge that. Capturing not only the implementers' voices, but also the Rohingya voices as well. So how should we do in our planning process to get their voices, what they really require for the planning processes? At least I'm happy that saying here, the UN agency is now thinking at least for the multi-year planning, not the multi-year funding, but at least you start the multi-year planning. That's a good thing because then you can bring this knowledge on your planning process at least, So I will stop here, maybe adding here, yeah.
No, I just want to add on accountability. I think accountability is not about assigning blame. Yeah, I think accountability, we should create a culture where we are talking honestly about the challenges. In this report, what you have put there, it really thinks that we should all look because it's something evidence-based and it's a challenging. Maybe some of us will see it, but like, oh, no. But they are evidence-based. So if we want to really keep accountability, we have to be honest on our challenges and then us collectively try to find a solution. If we are not honest about ourselves, about the challenges, it will be again talking for another year. That's what I would like to add for accountability.
Thank you, Juliet. So now we move to the fourth question. So this is for Dr. Rubaiyat, and Akram, if you want to add something, you're welcome to. So the last recommendation is uphold health for all. So the Commission calls for health for all and specifically names sexual and reproductive health as a non-negotiable component of humanitarian response, not a supplementary service. Yet reproductive health is often the first thing cut when the funding is tight or there is some political sensitivity, assigned to it. How do you navigate that in Cox's Bazar? And what would it take for reproductive health to be treated as core infrastructure rather than a special program?
Thank you. I think most negotiated service is SRHR in real context and which should not be as per the recommendation. And I think everyone, when they think about their own health, the non-negotiable thing should be SRHR. So thank you again for the commission for bringing this, I think, issue in the report and for their strong recommendation. One of the biggest challenge for humanitarian setting is that we all think about in a context with a perception that this is only emergency. We don't need to think long term, not need to think about establishing something which should be present as a routine thing. And as you correctly mentioned, that SRH considered, okay, don't go on that. There is sensitivity. People may take it as an very negative issue. And lot of time when we work, particularly since 2017, when we start working, we found that lot of actors were creating more obstacle than support for establishing SRHR. And fortunately, in Bangladesh, we observed that the government of Bangladesh were very much generous to provide support and provide all sorts of cooperation for moving with the SRHR. But that was not the case with a lot of national and international actors, development actors. So when we think about long-term plan, I would like to give one example. But we were the part of SRHR working group, RRC, and the Ministry of Health, that for the humanitarian response, we work with UN agencies, IPAS, RRC, and the DGFP particularly, and later on for the Ministry of Health and other ministries, to develop a strategy for providing family planning services for the Rohingya refugee settings in Bangladesh. So that allows everyone to follow, and then it gives us a comparably a good guideline what we have to do, what are essential, what we have to follow. So that is one example. But in general, we also, from the very beginning, we focused on investing on health workforce, build their capacity, orient them about the culture, customs, and sometimes we also focus on the local languages. At the same time, the training need to be competency-based and situation-based. Particularly when we initially initiate the services, we were, let me share my experience in 2017. I visited Balukhali Health Complex. It took about 10 to 15 minutes from the gate to the service point because it was so crowded and there was only 2 service providers. So we cannot bring out the health worker for training. And we have to, I think, first some resource to hire a health worker and then train on job training from the very beginning. So it need to be context specific training, but at the same time, there should be a long-term investment for building and workforce in the country context who can respond in some emergency settings or emergency situation. And then the situation is to ensure the commodities. We need to ensure the supplies of the commodities. And one of the challenge for reproductive commodities, particularly they are not readily available sometimes, particularly if it is long-term method, then the commodities availability is an issue. And another thing is that when we work with the communities, we have to reach the communities and gradually engage the people from the humanitarian settings. And I think one of the missing part for Bangladesh, particularly on health services, SRHR services, that we are only depending on the health worker force from the outside. Outside means not from the community, from the humanitarian settings. We need to invest on those people who came and build their capacity, at least for ensuring the primary health care. And that is the most missing part in our response. And we also think long-term commitment. It is easier on an acute crisis to get a short-term commitment, but long-term commitment is not very much visible in these sectors. And one of the very interesting and very strong recommendation I say in the report is pool fund mechanism. And that should bring into the attention of the donor and make them accountable to fund through pool funding mechanism, and the necessity, the need, whether for SRHR, the abortion care, the contraceptive care, GBV response, or any other services that can be assessed on the need, on the opinion of the community, and the and as per the priority, and then designing program should be focused on ground level reality, and that is missing. Thank you.
Thank you, Dr. Brad. So my next follow-up question is to Juliet. Juliet, you have written that placing hope at the center of humanitarian support is non-negotiable, that the Rohingya refugees restoring hope means creating conditions for people to see a future again. Does dignity look like operationally, not as an aspiration, but something that can be designed and funded? That is a tough question. Dignity. I think we all understand dignity the same way. The refugee today, they had a dignity in their home. They didn't want to flee, but they were forced to flee. And when you're forced to flee, you leave everything you have home. Yeah? You was living in the villa, today or living in the tent, you like it or not. Is that dignity? And also, refugees today, we may be sitting all of us here, and tomorrow you never know where we will be. And I always say that what can you give refugees? People say, oh, we need the food, we need the wash. To me, I will speak personally. To me, what is dignity is not a food. It's not a shelter where I'm going to sleep. It's giving me the means, get out of those misery. And the means, it's education. I was very sad last year during the prioritization when we talk about life saving. Education was not prioritized. So to me, I think education, it should be #1 priority. Because if you see the kids who have born in that camp, today they will be 9 years old in July. And so what is their future? If you see the youth sitting there, what is their future? So collectively, I think we need to work hard to give them a means to get out of that misery. We cannot say as humanitarian, we're going to get them out of there. Themselves, they will get out of there. How they're going to get out of there, you have to give them that means. They have to have education so that even
them when they are here. Give them education, skill development. It's not everybody to be doctor, everyone to be doctor, yeah, but those skill development, they will contribute to their country. So storing dignity, I think here we are accountable, talking about accountable. We're accountable to contribute to giving them dignity so they can go home with dignity, or even when they are, they can help themselves. Our new high commissioner, he's saying he was actually a refugee also. And I'm so happy that he openly talk about that. If we didn't have education, he would not be high commissioner today. So his aim is that we want to help these people to help themselves, to get out of dependency. And I think that is how we can restore dignity to Rohingya refugees and also to other refugees around the world. And I think one day I was sitting with my brother Triple RC and say that these people, they will not be refugee forever. One day they will go home. I was a refugee, I can tell you, I'm so proud to say that I lived as a refugee for many, many years. After my parents was refugee for 30 years, they went home. But we didn't know we're never going to go home after 30 years. So when you are home, they are telling you, we prefer to have a park national for animals than a human. So you are back there in the refugee camp thinking, how am I going to go home? But I believe in hope, and I will continue saying it. One day they will go home. I will not be sitting here if I didn't have education. So when we talk about what can we give refugees, for me, education. You eat it today, I'll come to your home, you give me food. But tomorrow I will not be able to get that food for myself. So if collectively, because we are here and we have to not keep thinking about day by day. We have to think for long term. I know here it's difficult to think about long term because we think these people will go tomorrow. But I don't want to disappoint you or to discourage you. Nowhere we open a refugee camp and then they have left 1 year later or 2 years later. Look in Dadaab, 30 years there. Look Kakuma, 30 years there. So it's not that there will be 30 years here, but we also, while we are supporting them here, the political people have also to work because they will not go home if the solution is not found where they come from. That's where I think in this report you have also mentioned the political people have to go together to make sure the solution it's happening where they came from. Because if not, we continue doing the same thing every day, trying to, of course, we don't have funding anymore. Now we have to prioritize how do we support these people. Now you can prioritize until when? Every day prioritize. I think we need to now think for longer time for better education, skills development, and also those who are not. Another one thing I would like to say, dignity for the girls. I think my brother here, you mentioned the girls in the camp, women in camp. The women also in the camp, they can do things on themselves, not about only education. They also can be part of the community. They can be leader for their community. So that also we have to be looking on that. You talked about multi-year planning. That was eye-open for all of us because now we can plan from 26 to 29. And there you have an opportunity. If you want really to put that education, you can monitor how that goes. So I think we should also not come out of planning every day, day by day, year by year. And also, we need to sit with the donor to tell them those time is over. Now we have to look differently. I think also the donors are looking things differently. So we need not to think to plan for tomorrow or after tomorrow. We have to plan at least 4 years. And then, if in that 4 years the refugee they have an opportunity to go home, Alhamdulillah. That's what we all want, and that's what also they want to go home. But this multi-year planning, I think it's also key that we can start thinking about that, and then how we can restore the dignity to these people. So I thank you very much. And I will say again, this report, I hope you are going to share with everyone because it's eye-opener. And then those recommendations, I think all of us in this room, we need to use them. I think if we come after 1 year, you can come back and say, what did you do? Which recommendation you have were able to implement? What was the challenges? So I really thank you for that. And we are open for any challenges, anything you see that we are doing wrong. This is a time. This is a time that we need to change the way we do things. We need to think outside the box. Thank you.
Thank you, Juliet. The question was difficult, but the response was also very powerful. So now we will open the floor for questions, one question per person. And please introduce yourself first and then ask the question.
Thank you. My name is Abdul Jabbar. I'm working as like deputy project coordinator at the BRAC James Buchanan School of Public Health. So we know that World Cup football is going, and we observe that the most of the like European team, they like half of them like footballer, they're mostly come from like Africa. Most of them like background was like from the refugee background, and now they are football. If we think about our like Rohingya people, I worked for like 4 months there. It was like full field work, so I observed a lot. So there is no formal opportunity to work. So you are talking about fixing the money by donor, but if you think about like long-term effect, so this is I don't think that this is like sustainable something. So with alongside with this like donor support, I think we need to like work with them, that to make them efficient somehow, maybe technical training, and then providing something to work. So if they have like this kind of opportunity, they will be, if they can at least have like independent earning source, so that they can sustain. Otherwise, what happened, maybe after 20 years they will back, and there will be like another camp. There will no like technical person, for example doctor. So from this like 13 lakh people, there is no like MBBS doctor. I met a student there who was like secondary student of medical college, but they just stopped their education. So there will be like another camp. So this is not solution. So I am a like Rohingya boy. So I'm 14 years old. I came here when I was like 5. I have that right to be a doctor. So that system, I think we need to discuss. So thank you so much.
Thank you for your important perspective. If any, okay, I'll take a few more questions, and then we can get back to the panelists.
Here you presented the situation crisis and their challenges. But I am also comfortable to share some perspective of the natural disaster area. So there are so many challenges and needs are different. There's the 2G context to the natural disaster area. So recently I had some experience with the disaster affected pregnant women, how they are facing challenges during the disaster to go to the shelter and to access the
out of 15 or 16 women, I found 3 women. They had stillbirth after the disaster, so they had to go to the high water level of water to go to the shelter or access some other services. And some of them, they shared, and many areas, they shared the health facilities are damaged because of flood and also cyclone, and they cannot access the life-saving services. The reality is that traditional humanitarian actors, they often don't prioritize this societal need and the general need as the life-saving service. So that we need to consider, we need to prioritize that. As a policymaker through this report, I think that the policymaker would change their mind and prioritize this. Need of the adolescent girl, the ministerial health management need. It might seem as a very small subject, but during emergency, we found that many girls, they were only sitting in a corner of the house without having any menstrual cloth or menstrual pads. They cannot move around, they cannot go to school. So this is small support, but impact is huge on them. So we have to prioritize this kind of need as well. And another thing is breaking the silence. As we always think that health, reproductive health, sexual reproductive health, the role of Ministry of Health or DJSS, DZNM, they are proud of the responsibility. But disaster management and relief, they should sit together. All humanitarian actors, they should understand the need of sexual reproductive health and gender-based violence. Again, the health workers also, health officials, they should understand the humanitarian. Bangladesh, such a country, no development work will sustain without having proper disaster risk reduction and the humanitarian preparedness and response integration. So this is very important to bring out. And another thing, dignity and accountability to the affected people. So this is another issues I think we need to think about, that always to prioritize that we think that we have many tools to apply. We are practicing those giving our humanitarian preparedness and response. But whenever we think about the inclusivity, the people with disability, whether they can understand the message or not, or how we can disseminate this information to the all people, all women, considering their level of understanding, level of their language. So everything we need to consider. So finally, I'd like to thank you for giving us this opportunity. This is very useful and powerful tools for our future work and for advocacy. Thank you very much.
Thank you for sharing your perspective and question, and we can.
So I'm Ashraful Janat Shukti, statistician from JPGSPH. I was wondering, when we discuss forced displacement, we often focus on recognized refugee crises like Rohingya refugees. However, there are also situations where families, women, and children become stranded in border areas or no man's lands for prolonged periods. If such situations become protracted, should these populations be considered within the broader framework of forced displacement, even if they are not formally recognized as refugees? And how should health system and humanitarian actors address their long-term health and protection needs? Thank you.
So Akram Bhai, I will first give it to you.
Yeah. I think I will come to you. I will come to you. I think two questions is basically for you. The first one and the last one also. But I think there's generally what I just pointed 2 points here. That's shared responsibility is very important, and that shared partnership, because the state definitely will take the lead where the crisis happens, but other agencies, either in national agencies or international agencies or any agencies, basically really need to work with the states. Because we really can't handle this, any crisis alone. That's the main, issue that we need to hold on. So all partners need to do that. Crisis, as far as that we served. I think if you are for the people that we serve, then we are accountable to the system. So you don't need to be accountable to the separately. You the choose the individuals, the families, or the communities. So it's really fair enough. And also for BRAC. So we see this as well in the camps, because we have a recent experience that so we form small groups, and we ask them how and when they can solve the small issues by themselves. They were very encouraged actually. When they are putting together a team, so they discuss together. They like in when they say, look, with this is very simple issues. We can do it. You don't need to invest resources here. The partners, we need to clean ourselves here. So you see, so I think this is just for general. I heard some comments. So it's basically share turn on the first.
So, in fact, I was forced to share my reflection by that question because it relates my older reflection also that is missing in the discussion, and I missed that point also during my discussion. The political perspective of the Rohingya crisis is very important to consider when you think about the all health issues and other issues. Rohingya refugees are unlike, other refugees all over the globe. That my understanding, Juliet can correct me. Because these people were made stateless. We are thinking that they will go back their home. Where is their home? They were made stateless, homeless. Because they were disenfranchised. They were escaped off from their citizenship. And gradually it was done for 40, 50 years tenure. It was done. Starting from 1961, and still it is going. So if we cannot consider their status, refugee status, as a political status, Bangladesh government, what they are doing, in fact, we need some advocacy with the government also from humanitarian side, because we must need some political decision from Bangladesh government side. You can go for 3 years plan, you could go for 4 years multi-year plan. How? Because Bangladesh government considered this crisis as a temporary one. Though it's 9th year, and there is a permanent temporariness, But still, the houses with, bamboo, tarpaulin, nothing is permanent. Infrastructure is not permanent in nature. So, because government is thinking that they will go back. But if you examine the, arrangement signed between the two countries, you cannot make your hope that these people will go back. Even, I'm sorry that I'm a government officer, I'm criticizing the arrangement signed between the two countries. Now, the politically sensitive question is that if we are doing everything in line with the humanitarian principles, international laws, these are becoming the pull factor for the other people living on the other side. Because the condition is very bad on the other side. We cannot prevent these people coming inside. Even the BGB is trying their best to prevent them.
but they are in a very dire condition on the other side. If you do not have any political consensus in the region, Bangladesh will face a trouble. And Bangladesh is being considered as a dumping ground of the stateless people. Now you see across the border, people have been made stateless and they are being pushed in Bangladesh. So we must not be considered as the dumping ground of the stateless people around us. That's my understanding. It's a very political question. And we cannot solve this problem alone. And Rohingya crisis is not the separate, segregated crisis from this region, because in the last 2 years, we had to receive more than 300 Rohingyas from India. And most of them have the UNHCR India card. So this country is not Rohingya country. This is not homeland of Rohingya, but why India is pushing Rohingya in our country? This is a big question and political question. So we must not miss this point whenever we are talking everything. Of course, I support Juliet and also brother who raised regarding the education. You see, the people in the camp, you will not find a single MBBS doctor or engineer. They had been their home. They were deprived of education at their home, here. Rather, we allowed the Myanmar curriculum to be studied in the camp. It's up to 12th grade now. But real problem is that there is no assessment authority. There is no certification. But still we are providing the livelihood. Even today, one digital learning center will be launched for the youth dropped out from the secondary education. And yesterday I had 2 meetings one with the AUW, another one with the Cox's Bazar International College, University. They are also coming up for providing the tertiary level education. I don't know how they will manage, but I'm open for education. But that actually will not be solution so far if we cannot go for political solution. And the players in the European teams are playing very good. They are the refugee, but you must not forget that these European countries are the colonizer of their countries. And they have started all resources from their country, and now people are coming there to make sure. We are not colonizer of the Rohingya. We are not the colonizer of the people who were made stateless on the other part of the border. Why should they come here? Rather, we are extracted by the colonizers, and they made this problem here in the subcontinent. Now we are fighting each other. Anyway, thank you.
Thank you very much for that you are champion for education. For education. And I wish opportunity for so we can do distance learning. So then it doesn't have to be a big school thing. So can we get a laptop for the kids or iPad? They can do that. And then see that's that they have the status, but it's not going to be easy. That's why this Can be
Thank you, Juliet. We are running out of time, and I had some closing lines written, but it's irrelevant now because the conversation has become much more interesting than I thought. And I believe during lunchtime, we'll also carry on with this conversation. Those who didn't get the opportunity to ask questions, feel free to reach out to the panelists and ask your question. So by saying that, I thank all the panelists for honesty and generosity. And now I would like to close this panel. Thank you, everyone.
Thank you so much to the panelists and to our wonderful moderator, Dr. Farzana Misha. We had a really lively discussion, and I thank all of you as well for engaging and participating and sharing all your insightful comments. As we approach the close of our forum, I'd like to invite Professor Martinez back on stage to share a forward-looking proposal on the Commission's work going forward.
Thank you very much. And if I could have, please, the last slide. So, thank you. So, the current health system and the humanitarian system in general, which is basically discussed, is buckling under pressure. And I really would like to echo a point made in the panel before, that when a system fails, the question is not who is responsible, but who suffers. And I think that's really a critical point, because at the moment, that is a call for action. We cannot just simply let the system fail. We need to find a way to actually move forward. There is an estimation by the Lancet that says that only with the USD funding, there is an expected 14 million excess deaths in the coming years. And there is already a lot of data coming out of patients that didn't receive or are not receiving HIV treatments, and therefore are now dying of AIDS. That was something that we were not hearing before. So there is a lot of issues that compel us to work together. And this next 2 minutes is basically to talk about what the Commission envisions as the way forward. Because there is no lack of evidence of lack of knowledge. We know what works and we know what doesn't work. So the idea is how we move forward in this multi-crisis environment. And it might sound idealistic, but the reality is that if we collectively work on this, we can advance reform and changes. And someone asked, can you disseminate the report widely? We asked you to disseminate the report widely. We really work, it's a 70-page, the complete report, and we really work hard to make sure that this high-level academic report is readable by people that are non-health, that are non-lawyers, that are not humanitarian practitioners. So really work hard on making it accessible in terms of language and recommendations. And within the report, there are as well policy briefs, and you can find them in the QR at the end, where basically if you are in a humanitarian organization, if you are in a UN agency, a government, or a regional body, then there are things that we can already do. Besides that, we consider that moving forward, there are a few things that can be done. So the first one is there will be, following the regional events, after we complete them, we are planning to convene a global humanitarian alliance. And this will be a members-based implementation platform that will include from affected communities to global players governments, organizations, religious, faith-based organizations, and so on and so forth, donors, academia, to discuss how can we actually make the recommendations of the report actionable. And the Alliance will support transformation through existing institutions and reform processes, and it will not be a parallel delivery agency. And here you will see the three main engines that will drive that change of that alliance. And I want to highlight that the previous conversation here shows how sensitive and politically sensitive some issues are. So a global humanitarian alliance that doesn't belong to a specific organization provides a neutral ground to have these conversations and to bring sensitive issues where often we have disparate views. So the three engines are a humanitarian observatory that will measure changes in the system through a curated set of indicators, a public dashboard, and data repository, and produce a biennial flagship report. In the middle, you will see a humanitarian transformation lab that will test reforms through applied pilots and through identification, as already was mentioned here, of practices that are already taking place in the ground that can inform change in other contexts. Also, to test policy packages and implementation learning across governance, financing, protection, and crisis-adapted health systems. And I mentioned before as well in my presentation, the setting up of a global alliance for the protection of health in conflict that advances the protection of civilian health by convening states, UN entities, and NGOs to strengthen the protection of healthcare, accountability, and coordinated action on attacks and other threats to health in conflict and forced displacement. But we invite you, this effort is going to be collective and is going to be global, but anchored locally. So we really invite you to stay tuned and to be part of this work when it's launched. And in the QR that you will see here, and you will find as well in some of the leaflets that are around, you will see updates when they become live. So with that, I just only want to say thanks to you all, to the members of the panel, and to our chief guest for being here, to all of you for being part of this conversation, to the colleagues joining online, and to say, let's work on this together. There are things that each one of you can do, and we must do in order to change the status quo. So with that, I hand over to Sabina to wrap up. Thank you.
Yeah, I'm going to keep it short, but I found the entire morning and the panel discussions extremely powerful. Juliet's personal experiences really, spoke such volumes of who we don't know and understand, but how much people are trying to do. But I come with a few thoughts and reflections, which is there's certain principles that the Lancet Commission and people on the panel speak to, which is public health is not just disease, it's much more. It's about well-being. It's about health. If you don't have food or shelter or education or skills, then we're back to zero. We really leave them in limbo. Many of these affected communities, and many of them are in limbo. We keep hearing from everyone, and I think it's obvious, but often not paid enough attention to, is communities, people, diverse, vulnerable groups, populations, refugees are at the heart of everything that we should be doing. And if that's not the starting point, then we're actually starting with failure. Because many of them, due to inequitable power or lack of voice or fear of persecution or having services stripped away, will not share, cannot share, and don't have the avenue or the platforms to share, which means gender, more marginalized women, which means young boys were often left out because we only focus on young girls who are, of course, disproportionately affected, disabled, people living with disabilities, ethnic minorities of a different sexual orientation. Do we need to remember this when we talk about communities? They're not homogeneous, refugees, diverse vulnerabilities. Finally, to Sarah's point, but I think this is very complex. State, limbo, citizenship rights, problems and challenges created by external politics. So even when we talk about localization and taking ownership of sustained engagement and global accountability of resources, because you could transfer localization, locals, but the communities who are affected because you don't have the funds. So I think global accountability is critical. It's not about just creating the problems. And I think back to even Juliet, sorry, I keep quoting you, but some of the is recognizing some of these deeper challenges and then saying, okay, let's get together and try and make some changes. Ultimately, polycrisis will go on centuries, it'll continue. Does that mean we do nothing? Or does that mean, as Esperanza, there's a leadership small things together, we prioritize their communities' needs, we be diverse. Remember, we're here who are most affected, not for ourselves. Thank you so much for joining us today. I think it's lunch, right? Yeah, it's lunch, and I will be speaking to our panelists, not to exclude the panelists, and I'll be to come here with Esperanza and some of us, just take a picture. And for the rest of our audience, thank you for joining us. Taking do join us for this hot lunch outside. Thank you.